This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular Grand Rounds. I hope you had a nice weekend. There was a change over the weekend. Instead of Dr. Clements, we have Dr. Spencer King, who has kindly agreed to present this morning. It is truly a privilege to be able to introduce Dr. King this morning, who really needs no introduction. He's a professor of medicine at Emory, served as the director of the cath lab in the 70s here, director of interventional cardiology, director of Emory cardiovascular databases, past president of the ACC and the Society of and the PSI, and also just so many firsts with Dr. King. He's been directing the training program for interventional cardiologists and has trained over 150 fellows. Also, really a pioneer and a leader in interventional cardiology with over 600 papers, co-edited the Hearst cardiology textbook, has served on many national committees, founding editor of JACC Cardiovascular Interventions. He served as a PI or on steering committee of more than 15 clinical interventional cardiology trials, including the first trial for coronary angioplasty versus bypass surgery through NHLBI. He's received numerous lifetime achievement awards, including the award for lifetime achievement with TCT, and more recently, Helping Hearts Lifetime Service Award, the Ithaca Award with the European Society of Cardiology, and honorary fellow of the Japanese Circulation Society. I can just go on and on, but I'm going to turn it over to Dr. King. Thank you so much for doing this morning for us.
Thank you, Punta. Yeah, so I'm so sorry whoever's tuned in and hoping to hear Steve Clements' great cases that he always presents, and I was looking forward to listening to that too. But Steve's under the weather, and I'm happy to tee up something for you. I was a couple of years ago, I was a bit insulted by the fact that the guideline committee did not list coronary arteriography as a diagnostic method. Now, some of you do this, and I'm defending you today that this is indeed still a diagnostic method. But the imaging methods that were listed in the guideline were like ultrasound and echo and intravascular imaging and so forth. But diagnostic coronary arteriography in the guideline is referred to as a test you do in preparation for placing stents, and not a diagnostic test. And I took offense at that. And then more recently, I was giving a talk in Korea a year ago, and someone asked me to give a discussion of coronary arteriography in a debate with someone talking about CTA. And I was a bit of a disadvantage there, but I tried to do it. And then last week, they asked me to come up to Boston and talk about that subject of coronary arteriography at the Grand Rounds at Mass General Brigham. And so I did. So that's what you're going to hear today, because that's what I've got. And I call it imaging coronary arteries from Leonardo to Photon Counting. So obviously it's a historic bit of thing that you may or may not take notes on, but it will be worthless to you. But I will hopefully tell you something entertaining. No relationship. So coronary arteries have been looked at, imaged for a long time, very accurately by Leonardo da Vinci, as everybody knows. And he got a pretty good idea about it. But there were a lot of things that we did that we heard about before coronary arteriography. And if we do a quick run through the history book, we'll realize that 600 years ago, yeah, people were looking at coronary arteries. Circulation was described by Harvey in 1600s, and then later Richard Lauer used injection techniques to show collaterals. Röntgen discovered X-rays in just almost 1900, and immediately after he discovered X-rays, people began to put them to work William Morton injected radiopaque material into cadavers to see what it would look like. In 1910, there were some radiopaque substances injected into animals, and 20 French physicians had used Lopiodol as a contrast agent in animals, and Mayo Clinic tried sodium iodide intravascularly. And all that was done before Forsman had catheterized his heart. So all these things were happening with trying to see what's going on in the body. And then modern catheterization occurred, in the World War II with Coronary and Richards, and here at Emory with the development of catheterization down at Grady. There was Heinz Wiens and Jim Warren, Gene Stead, and interesting developments as Emory was added to the Department of Defense contracts to try to develop things to investigate cardiogenic shock. But nothing with coronaries. And in the 1950s, there were people trying to see the coronaries a little bit with aortic root injections. Sven Pauline in Boston had a little catheter that would go down and squirt in the aortic root and hope to see something. But no one was dared to enter the coronary arteries. And that was until the very late 1950s. Now, what was going on in treatment in the late 1950s? Here's a picture of Dwight Eisenhower on the roof of Fitzsimmons Hospital after he had suffered a myocardial infarction. And it's interesting to reflect at this time. It's interesting for me because this was the same year I graduated high school and began to be interested in medicine as a career. So I'll date these two things as an interest of mine. Well, what did they do with Eisenhower back then? They didn't have coronary arteriograms. They didn't have a whole lot of things. The diagnosis was a history, and the history here was wrong. The history was a GI. They'd been treating him for his chest pain all along with various potions for GI conditions. But when they finally discovered he had an infarct, they gave him morphine, they put him in an oxygen tent for a couple of weeks, he was in bed rest. And then the follow-up was, look, you ought to retire. And remember, he was running for re-election in 1955. And Paul White, among others, said, look, don't do that. In fact, maybe with heart attack, you ought to get more active and try to rehabilitate yourself. And this was all new stuff. But nobody looking in the coronaries until someone dared to actually do that. And that was Mason Soanes at Cleveland Clinic when he was catheterizing a child, doing an aortic root injection. Here he is at that same time in the top right. In the bottom right, you see the catheter had slipped into the coronary artery and the power injector had gone off and the artery filled, and everybody was panicked that the patient would die, but he didn't. And Soanes said, well, maybe we should try this intentionally. This is a painting I commissioned for the Society of Cardiac Angiography when I was in charge of it. And this was a painting of Soanes and Mel Judkins. Mel Judkins had simplified the Soanes technique by making it percutaneous. Soanes was doing a cut down in the brachial artery to do his coronary arteriograms. And Judkins thought he could do it with the technique from the leg using a Seldinger approach. On into the 80s, I put together some of this stuff in a book that John Douglas and I did on coronary arteriography. And I pulled that book out because it sort of reminded me of some of those early days. Mason Soanes never wrote anything much, and he would not write he did write a description of the first case, which he put in a chapter that Willis Hurst did on the history. But Fred Hupler described the Soanes technique, and he it had beautiful illustrations. I think the best description of the Soane's technique I've ever seen. And it included the equipment that was used. And here's the layout of all the equipment used for that brachial cut down to do coronary angiograms. And I see all these things, which reminded me of when I came from Denver back to Emory in 1972 to start the cath lab at Emory Hospital. There was only one other person doing coronaries in Atlanta, and that was Arnaldo Theodotin down at St. Joe's Infirmary. And Arnaldo was doing the Soane's technique and had trained there. So I let the first fellows go down for a week and scrub in with Arnaldo to get an idea of that technique, although we were teaching the leg approach. And one fellow came back and he said, I was down there, and after a while I discovered there was a long forceps that Dr. Favalero had on the Mayo tray, but he never used it. And I asked him why he never used it and he what it was for. And he said it's for holding the cigarette. And I said, well, you don't smoke. What are you talking about? He said, well, I don't, but Dr. Soane's did, and I do everything he did. So this was the how loyal a disciple of Soane's Favalero was. I got Mel Judkins to write a chapter, and it was an extensive and very beautiful chapter on the Judkins technique. And one of the things about the Judkins chapter was that his illustrations were the way he did coronary arteriography. He did not use film. He used these big plates, these still plates with a Franklin changer. So the Judkins catheters were put up, preformed catheters, up into the coronary arteries under fluoroscopy. Then he would take the fluoro away and bring in this Franklin changer, and it would have a series of X-ray plates in it. And they'd go out in the hall and push a button, and these plates would go bang, 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 and then you'd collect them up, take them off, and develop them. Well, one thing it did, it gave them incredible resolution of these coronary arteries without any raster lines, without any pixels, without anything. It was just a pure image on an X-ray plate. So those were interesting. We reported our technique, which we had reported previously in circulation, of the multi-purpose technique. And so obviously we wrote a chapter in the book about that, and had all kind of illustrations of how you accomplish that technique with the maneuver of the multi-purpose catheter from the femoral approach. The whole idea of that approach was that the Judkins approach required multiple catheter changes. And early on, there were no sheaths. The catheters were put in over a guide wire without a sheath. And when that was done, there were early complications reported by Adams and Abrams in Boston of material being picked up and embolized to the coronary arteries with the catheter changes. And that's why Fred Schoonmaker, my partner in Denver, decided that we'd try to do it with one catheter and not have to make catheter exchanges and avoid that technique, that problem. But the Soane's catheter didn't work from the leg, and we ended up settling on a Cordis catheter and used that, and were able to develop maneuvers to get that into the coronary arteries, and that was what constituted the multipurpose percutaneous technique. Also in that book, we had a chapter on new views of coronary arteriography. Sounds strange now, but the patient was lying flat on a table, and to get the views you needed, you had to do certain things, and had, by that time, a cradle, so the patient could be rolled right and left, but there was no way to do cranial or caudal angulation. We had to put a wedge under the patient and tip them up, and then roll them onto the left side or the right side. And sometimes the patient would fall off the table, but If you'd get enough people, you could hold them in place. And it achieved these views where you would not have foreshortening or overlap and all the problems that we're familiar with angiography. So we did that, and we tried to teach people what those angles would look like and illustrate it. Another interesting thing, these pictures are from a camera that I acquired. There was this large format camera, about that big, that about 3 by 3 to 4 inches, that would snap these shots at about 8 frames per second to kind of simulate what Judkins was doing. Only did that for the illustrations for this book, but you can see the effect of adding the cranial angle to view this proximal LAD lesion. I used various teaching techniques. This is a gadget we developed to be able to illustrate the course of the anterior descending and posterior descending artery and the AV groove part of the circumflex and the right. And then with a light source, you could project this on the wall and show how rotating and angling the patient cranial and caudal would give you the desired views without overlap and the optimal views for seeing the coronary arteries. That's how we used to start out teaching coronary arteriography. So what was for back when Soames developed this? It was not good for much except interesting pictures, because the only thing available in the early 60s was indirect surgical techniques like the Weinberg procedure. And yes, you could identify somebody with coronary disease, and the surgeon could stick a internal mammary artery into the myocardium, hope it would bleed and connect up with the arteries somehow with collaterals. But and when I was at Emory, we sent people to Cleveland for that procedure. But by the late 60s, direct coronary bypass surgery was coming into the fore, and by that time, coronary arteriography had a real use. So 3 disciplines collided, came together to create a new therapy, and they were coronary arteriography, direct bypass surgery, and the fact that radiologists showed you could open obstructed vessels from the inside. So there were these 3 things that came together that enabled a new technique, a new way to skin the cat. So coronary surgery, vascular radiology, and cardiology were the grandparents of coronary angioplasty. So obviously, we'll talk a bit about coronary angioplasty, but Rene Favalaro and his work at Cleveland Clinic was what made coronary arteriography really a useful technique, and it spread across the country and around the world. Charles Dotter in Portland began passing catheters through the femoral artery to do diagnostic angiograms, but discovered that he would improve the circulation to the leg and improve the symptoms of the patient, improve the claudication. So the Dotter technique became a thing. And it was not very accepted in the United States, but in Europe it was. The man on the left is Eberhard Zeitler in Nuremberg, who was a disciple of Dotter, took the technique to heart and started using it, as did other Europeans. And Andreas Grunzig, a young angiologist in Zurich, Switzerland, went to a course put on by Zeitler when he had brought Dotter over, and Grunzig said, "Oh, that's an interesting technique," and Grunzig began to do it in Zurich in the early 70s. Grunzig obviously knew that he could never apply that in the heart. He was interested in the heart. He later got into the cath lab and began to do cardiology. But he said, to make this work, it's got to be miniaturized, and we have to have a catheter that will go in as a small device, but when it gets where it's going, it'll have to become bigger. And what does that? And what does that is a balloon. So his concept of the balloon was developed, and in 1976, he brought this poster to Miami, to the American Heart Association, to illustrate the concept of balloon angioplasty. And it was a dog experiment. There were no patients done yet. It was a ligature tied around the coronary artery of the dog, the balloon catheter inserted, the balloon catheter he had made in his own kitchen, or his wife's kitchen, using polyvinyl chloride, which he had been taught about by a chemist, how to heat mold it in his wife's oven, and how to put it on the catheter. A lot of interesting stories about how he did that. They're very different from what finally ended up, but he applied it to the catheter and eventually used it in the leg of animals, and finally in the heart of a dog, as shown here. I had a poster on the other side of this, and John Hurst was a fellow at the time, and John was a fellow with me on this poster. And somebody came to see our poster and said, you should come around the corner and take a look at this one that this fellow from Zurich is showing. And I did, had a look at it, and I said, look, this is going to never work. That was my initial approach. But it had a lot of things in it. And a year later, he came back to the American Heart, and he showed this slide, among others. This was the first patient who underwent angioplasty in Zurich, Mr. Bachmann. And he showed the first four patients. You notice several things here. You see below the angiography, where the vessel is obstructed, narrowed there. He's passed the balloon down, blew it up, and you see it looks a bit better. But up above is the first physiology demonstrated for coronary circulation with balloon intervention, where crosses the lesion. You see a huge gradient between the proximal aortic pressure and the tip of that balloon, which did have a pressure lumen in it. He inflates the balloon, and you see afterward the pressure comes back up. Now, that pressure measurement was a very important part of the angiography, because the quality of the angiograms, as you can see, was not good. And Bernie Meyer has told me that a large reason that Andreas wanted to stick with the catheter that had a through lumen, which was true of the Grunzig catheter, not true of the later Simpson catheters. The reason he wanted to do that was that the endpoint of an adequate expansion of the artery and relief of the gradient was this pressure measurement. So the first FFR, if you would, it was done with those Grunzig balloons to demonstrate that the pressure was relieved. And many studies we did at Emory had to do with the pressure measurements at the time of angiography. Of course, everybody wanted to go to Zurich to see this, and it got crowded. And after a few cases, they said, well, Andreas, you can put on a course for a week. And he did. And this is the last course and the largest attendance. But before that, there were 3 other courses in Zurich in which Andreas, for a week, would demonstrate what it was all about. And at this last course, he said to me, look, I think I'm going to leave Zurich. And I said, why? He said, I'm not able to do what I want. I'm restricted in the number of cases, and I want to go somewhere else. And I asked him where he was going, and he said he had applied for a job in Germany. He may be going there, and if not there, to the United States. So I asked where he was interested in the United States, and he said that Cleveland Clinic was the place most famous for bypass surgery, and perhaps that would be where he would go. Well, that led me to ask him what he wanted to do there, and he said He wanted to guide the technique. He wanted to make sure it did not get misused. And he wanted to be a professor. He had this European concept of being a professor. And I said, well, that's all good, but you can't be a professor at the Cleveland Clinic because they don't have a medical school. So this kind of took him back, and he said, oh gosh, where do you recommend I should go? And I mentioned several usual places that were famous. And
waste it, but it's just too big for that little. So I bought one on.
and I said, maybe you ought to consider Emory. And he said, I'm going to Snowmass, Colorado next week to Jack Vogel's course, and been invited out there for the first time. And I'll call you from there. And he did call me, and he came through Atlantic on his way back to Zurich to visit. And when he did, I said, okay, this is great. Let me go over and talk to Willis Hurst about you. I did talk to Willis, and Willis said to me, look, don't get involved with this guy. He's a prima donna. I've heard about him. And he had heard about him. He'd heard about him from his former student, who was Andreas's chief in Zurich, Hans-Peter Kreinbühl. Kreinbühl had been a resident at Grady previously for a year, and Willis knew him. In fact, Willis had asked him to write a chapter on angioplasty that year before, and he did, and he did not ask Andreas to even be participating in it, and Andreas was not listed in it. And so there was this enormous schism between Kreinbühl and Grunzig, and Willis Hurst had been fed this by Kreinbühl. So I said, whoops, I tell you, he's at my house. I would appreciate you at least meeting him. And so I brought Andreas over, and Willis, within short order, had been changed completely. He became enamored with the whole idea. He became enamored of Andreas's charisma, his interest in the scientific method and all that, and began to support my effort to get Andreas to come to Emory. So after, let's see, that was January, and he came in October. So after 10 months, he shows up. And it's a long story in itself, but after he came, and a large part of his coming had to do with our ability to put on the courses, which we did in the Woodruff auditorium, and we had a lot of people who would come year after year, twice a year, with live demonstrations, with Andreas performing most of them, me performing the rest of them. What you see down by his right hand, you've probably never seen, but that's how we displayed the film. That's a Tajarno injector, and that's 35 millimeter film that we bring over. And of course, we could see the projected video images because we ran a fiber optic cable from one of the cath labs at Emory, what was later known as Lab 3, over to the auditorium, buried fiber optic cable that's still there somewhere, and project those images on back project TV screens that were at that time called high resolution. They were not pixelated, they were still raster lines, but there were twice the number of raster lines in the normal TV. And you gave you a high quality image the audience could view from the auditorium. And we proceeded to hold those courses. We had people come and participate, such as Richard Myler here, who was first to do angioplasty in the United States. But these were just courses of demonstration. These were not lectures so much. They were cases one after another with the people watching for a week, absorbing them and then going home and doing them. Among the people who came to those courses, Mason Soames came. Here he is. Obviously, you can tell it's in the Woodruff building. There's Mr. Woodruff behind him. Geffredo Gensini had his own catheter. He was one of the, after the courses with the the parties that would happen every time we had one of these things. Andreas was big on parties. So what's the biggest development since the balloon? Is it the stent, the drug-eluting stent, imaging, atherectomy devices, guide wires? Well, the answer clearly is guide wires. At the same time Andreas was coming over here, John Simpson was working on a separate catheter, which was an over-the-wire catheter. And the concept of the guide wire was pivotal. The guide wires were no good at that time and didn't really improve the results with that catheter versus the Grunze catheter. And we stuck with the Grunze catheter. But after the guide wires became steerable, after they became deflectable, the companies developed all the techniques for doing that. Along about 82, the guide wire became the device that enabled us to take the coronary angiogram and direct the guide wire almost anywhere we wanted to go, as you have now. And that, I think, is the most important device in coronary angiography, coronary angioplasty. Of course, the most important application was angioplasty for acute infarction, which remains the most life-saving ingredient for coronary work. And many people are credited with that, but I give credit to Jeff Hartzler, who popularized this technique, pushed it, and was really viewed as a rival of ours, Kansas City. But I once went there to present a talk. It had to do with a very small catheter for crossing uncrossable lesions called the probe. And when I got back from giving that talk, Andreas was very upset with me. And he said, "What are you doing cavorting with the enemy?" I said, "Well, no, it's not cavorting. They're doing good things as well." So then, of course, the work of doing studies on this acute myocardial infarction work with Cindy Grinds and Bill O'Neill. Of course, that was all pivotal as well. As you all know, Andreas was with us for 5 years, tragically died in a plane crash in 1985. And before that, he was interviewed, and here's what he had to say about the future concerning the balloon and whether that was enough.
For most of our problems at the present time, the balloon catheter is quite a good answer. But the more we depart, as I said, to more diffuse disease, the more we have to change our directions to additional catheter systems, catheters or instruments, which then could solve problems like getting rid of a dissection, which is like a flap hanging in the lumen, obstructing the blood flow. Catheters who are able to eliminate embolizations, plaques, thrombi, etc. So we have to have more armamentarium than the balloon catheter only. We need more than that.
And indeed, more than that developed in the late 80s. I called it the new device era. There were a host of things that came along. We had meetings about this. One meeting in Santa Barbara that we used to put on every year with Jack Vogel. We wrote a couple of books about those meetings, and everybody brought all their new technology to these things. One of the important ones was the transluminal atherectomy that John Simpson had developed that would cut out. We thought that this was going to be important. Now we're taking the plaque out of the artery. Surely this would be a more definitive method than simply compressing it or expanding it with the balloon. Of course, he also came up with the Perclose device and a lot of other interesting inventions. Lasers were coming along. There were a lot of ones, the excimer laser, which stuck around, but some crazy ones. This one by Richard Spears called the laser balloon, which had laser within the balloon and was obviously didn't work. Rotablator, all kind of other atherectomy devices came around. But the one that lasted, of course, was the stent, and we entered the stent era. And I give credit to Ulrich Siegwart as really the first. The balloon expanding stent, the wall stent, was put in 1986, a year after Andreas died. And Siegwart had been working on this stent with the company in Sweden, and he put it in Denmark and in Switzerland. Same time, actually slightly before that, it was put in France, in Toulouse, by Jacques Puel, but that was something of a mistake. They were looking for someone else, and Puel got it and put it in. But Siegwart, I think, is the real guiding light for that company, and worked with the preclinical development and so forth. After that, of course, other stents were developed, but the problem of the stent was that, yes, it opened the artery, it held the artery open better, but it created more restenosis than we even had with the balloon. Andreas used to say that restenosis was part of the procedure. You know, 1 out of 3 might restenose, but then you could have it redone. So he kind of looked at it as just part of what this technique did. You were avoiding surgery, but you likely would have to come back for another go at it. Well, the stent ended up with more proliferation than we had without it. And that same year, a stent was brought to Emory by Cesar Gianturco, a radiologist. He brought this to Andreas, and then, as you know, died. And Gary Rubin was at that time our fellow, and along with Keith Robinson, they began working in our animal lab in '86 to see if this thing would be compatible with intravascular placement. So these are studies putting the stent in pig coronary arteries. We looked at a lot of things. We looked at electron microscopy. We looked at the platelet deposition on these stents and how they healed in the pig model, rabbit models, and other models. And finally, in patients, we got approval to apply this stent in a patient, in a group of patients, 10 patients, that we would put in not for restenosis, but to hold the artery open in the case of an acute closure. Now, I'll remind you that in the early days of angioplasty at Emory, we sent 6% of the patients to the OR directly from the cath lab because of acute closure and ongoing obstruction. So in order to not have to crash directly to the OR and have damage in that lost time period, we wanted to put the stent in to hold the artery open until surgery could be done. Surgery, in fact, was done in those 10 cases. And we demonstrated the effectiveness of that, and the FDA let us do that. John Douglas had the first acute closure in that bunch, and he ended up putting in the first stent in that series that we had. So that was off and going. Restenosis, though, remained a big problem, and this was my thoughts and when we were first investigating those stents and what we might do about restenosis.
Perhaps by utilizing compounds that will tag to things that are in the vessel wall that will stay there over a period of time, and perhaps by placing stents or some other polymer material in the vessel wall that will elute drug over a long period of time. In conclusion, I would say that restenosis is a multifactorial problem that I think will be solved by, number one, improving the initial result of angioplasty, both by utilizing diagnostic and new therapeutic tools to end up with an artery that indeed is open and is not like some of these who've died that Bruce Waller has shown you. Secondly, there must be a biochemical approach to hold that artery open and reduce the proliferative response. It may be that the key to that is in thrombosis. It may be it's in a combination of reducing thrombosis and also treating a long, ongoing proliferative proliferative stimulus that may come from many sources, including inflammatory cells, including autocrine effects from dying smooth muscle cells themselves. And it may be that once potent therapies have been found, that we will discover that they're too potent for systemic use, which will spur on new development in interventional cardiology to find delivery systems for drug to be placed directly in the artery. Thank you very much.
Well, that was a vascular biology symposium, and you notice that I used the word polymer in the arteries. We indeed had been working with Bob Langer at NIH, at MIT, and Joachim Cohn at Rutgers on the idea of making the stents out of a polymer, a biodegradable polymer, which we had some back then, but we unfortunately dropped the ball on that early on and got away from it. What we did get onto was the idea that we could inhibit this proliferation this restenosis with radiation. And so the idea of brachytherapy came, and Ron Waxman had joined me in the early 90s. And so Ron was working in an experimental lab, and we got to look at the pigs there and began to use some radiation, and eventually teamed up with a company here in Atlanta called Novost, and they developed a brachytherapy system that indeed did inhibit restenosis, unfortunately inhibit the endothelial healing, and was abandoned as a technique for treating, with new stents. It also caused thrombosis, but stuck around a bit for treating in-stent restenosis, where the stent is buried well into the artery. And it's still, as you know, used somewhat for very refractory problems. The thing that replaced the restenosis, the brachytherapy, however, was the drug-eluting stent. And here's the celebration. I'll skip all that, but the celebration of the first look at 6 months follow-up of the drug-eluting stents that were placed in Brazil, in Sao Paulo. This is Eduardo Souza on the right, who recently died a year or two ago, and Patrick Suroy's on the left, and they're celebrating the first 15 patients who had 6-month follow-up, and they found no restenosis, and they thought they had solved all the problems. Some other people ought to be recognized in this journey of interventional cardiology. One of them is Antonio Colombo, who didn't do studies. He brought us a lot of interesting ideas from personal communication and personal observation. And one of them was that we were having a lot of in-stent restenosis early on. And he said we weren't deploying the stents well enough. We needed to deploy them so that angiographically on the coronary angiogram, we saw expansion where the stent was, like a pig in a python, and step up and step down. And he was right about that. We're not expanding stents adequately, and that was helpful. He also was important in emphasizing the importance of the antiplatelet therapies for the stent. And even lately, he's been a champion of the drug-coated balloon and avoiding stent. And so the drug-coated balloon, which is used extensively in Europe for in-stent restenosis, is now available. That's another technique that we had an idea about back in the 80s, because we had a balloon called a porous balloon that we had USCI drill small holes in, and we would inject material into the vessel wall to inhibit restenosis, but we had no agent at that time. We were using heparin. We did that. Keith Robinson did that with us in the animal lab. It did not work to inhibit restenosis, but the reason it didn't work was we had the wrong agent, so we abandoned that technique. But now, drug-eluting balloon is probably first line for in-stent restenosis in Europe, and it might be here if it didn't cost the blooming much. Intravascular imaging, I won't go too much into. You're all familiar with what's the revolution that coronary angiography has led us to, both ultrasound, OCT, the ability to do physiology in the vessels, the ability to look at pressure measurements that we saw, as I told you, very early in the days of angioplasty. Now, many techniques for visualizing the physiology, a lot of that work done at Emory. And now with all that, you are doing amazing things and things that we never would consider in the past. Andreas Grunzig, after 4 cases, told us that you should never do a left main because one of the left mains died suddenly. He thought it was due to spasm, but whatever it was due to, it was something that we never did, again, until stents came along. And now with that, routinely, you do left mains. And some, if tough ones, you sometimes put them on support, and you do long diffuse calcified disease. You use atherectomy to clean out arteries over long, extensive. Thanks for these pictures from Bill Nicholson. I think this one's from the Tanvir. Total occlusions. Emory's now main place for total occlusion interventions. Here's one Bill, I think, gave me, or somebody gave me, where you had a total LAD, you got a total right, you see the collateral still in the right. Back there, you see the circumflex is totally occluded. And then you open the LAD, the circumflex was open, the right was open. The angiogram teaches us many things. I mean, acute interventions, you run across things. All of you have learned that not everything is atherosclerosis. There's a young woman who has this anterior infarct going on, has this condition that everybody, hopefully on this call, says, oh, that's probably not coronary atherosclerosis. What is that? Hopefully you don't put a stent in it. It was, of course, a SCAD. It was a dissection. So the guideline committee may no longer consider invasive coronary angiography a diagnostic method. However, it was the essential method that enabled everything else, including bypass surgery, interventional cardiology, and the future assessment of medical therapy. For now, it remains, in my mind, a powerful diagnostic method, and that's my stand, and I'm sticking with it. Thanks for that. Now, what's coming for the future? The future is that we are going to do this non-invasively. You're all aware of the CTA. You're using CTA much more. Will CTA total replace the diagnostic coronary arteriogram? I gave a talk against this guy with the photon counting, and I looked at his images, and I said, they're cheating. You're photoshopping these images. This can't be true. But it is true. We don't have this at Emory yet. But I tell you, these are quite astounding images. And if we can see not only the artery, but the various components of plaque by just counting the photons that they absorb, see right through stents and so forth, then we're likely to get images almost as good as Leonardo did. And now, since I didn't rearrange my talk properly, I go to my conclusion slide, which I've already shown you, which said what I said already. I think obviously you continue to do coronary angiograms. You do it very well. It continues to be part of what we do, but time moves on. AI, everything else is going to be part of what you do in the future. But we should remember that coronary arteriography enabled cardiology as we know it today. Thanks a lot.
Thank you, Dr. King, for taking us through a very interesting journey of interventional cardiology. We're so fortunate to be able to hear the stories that you shared. I'll open it up for questions or comments.
This was not meant to be so educational as entertaining, so I hope somebody was entertained.
Spencer, Stan,
Yeah.
where do you think the training programs are going, Spencer? Is this all going to be interventional cardiologists? Is it all going to be surgeons? Where's the crossover and where are the training programs going with this?
Well, training programs ought to go with what we're training to do, I guess. So, notice that nobody knows what a Tagliano projector is. Nobody knows what cinefilm is. Nobody knows these things. Nobody knows how to drive a gear shift. I mean, I think it's important to kind of learn how we got where we are, but the training programs are going to have to concentrate on it now. Your question implies who's going to be doing all these studies. Is it going to be, or the radiologists just going to, do all the studies and then call the primary care or the general cardiologist is going to tell us, okay, this is a patient we've got with triple vessel disease, diffuse this, that, and the other. Here is angiograms. The CT angiograms. Here's what it all looks like. I'm going to send them to you to consider for surgery or PCI. I think that will be a good day when we get to it for this reason. I think that the ability to do diagnostic imaging without invasive procedure at some point in the future will enable patients living in South Georgia to have their doctor tell them, your syndrome sounds like coronary disease. I'm going to send you over to get an X-ray procedure to the nearby town, and the patient will have a highly sophisticated CTA, which will then be available online to the people at Emory or Wellstar or Northside, whoever's taken over by them, and we'll say, here's the patient's story, and here's what I want you to tell me you're going to do with him. The current situation is the patient in South Georgia is told, you might have some coronary disease. I'm sending you up to Macon or Atlanta or Augusta or Savannah somewhere, and take your family along because I don't know what they're going to do. They may put stents in you. They may operate on you. So just be prepared. And the patient says, well, that sounds like a lot. How about just give me some pills? So I think if we were able to view what was going on and extend the coronary angiogram to a diagnostic test that could be disseminated and done without the patient being committed to a procedure, it would democratize it, and it might cause trouble. It might create a whole lot more patients. It might create less patients. I don't know what it would do, but I think it's the future, and someday we're going to get there. So the training is going to have to parallel where we're going in the future. But for right now, people need to learn about all the techniques we have. But Stan, the missing ingredient that's never going to go away is training people to recognize what angina is in the first place and what it's not. And that is something that has not improved in recent years in training, but has actually been forgotten about. Sorry for that sermon, but that's.
No, thanks, Spencer, and thanks for all you've done and doing.
Yeah, we still need a Bruce Logue somewhere. It just says, yeah, you're talking about your chest hurting, but that doesn't sound like angina. Let's walk up the hill to Eggleston and see how fast you can walk up the tunnel. And the patient is walking faster than Dr. Logue is, and he says, well, you're telling me you can't do anything, but I don't believe you. So the patient is reassured and sent home. I mean, there's a place for that. There's another place for somebody telling they have some atypical symptom, but says, well, I don't know. we better investigate you for coronary disease because you somewhere for the clinician in all this. I don't know where it is. AI may figure it all out, but I think somewhere the AI information will bring us to the point of being able to pass that back to the physician. I just saw this old story everybody saw about the Chinese AI is better than the Chat GPT and everything will take us all over. I choose to think that before it takes us all over, I choose to be amazed at all the things that maybe it's going to be able to do to help us before it takes us all over.
Yeah, I don't think I ever met anybody who could walk faster than Dr. Loeb, though.
Right.
Dr. King, how good is this photon CT for bypass grafts imaging?
Oh, I mean, the bypass graphs I think it's pretty good with the CTs we have now, very good. But I don't know. I've never seen a photon imaging the bypass grafts, but I assume it's terrific. Tell where they're open and closed. I mean, the one thing you learn that I learned from the kind of CTs I see, which don't tell me a lot about the collateral circulation. They don't tell me a lot of things that I see on the diagnostic angiogram. I mean, I'm trying not to oversell the coronary CT. I had this argument with Patrick Surois, who published this study where the cardiac surgeons use only the CTA to decide to operate. And they had one group of surgeons had the invasive coronary angiogram to look at, and the other group of surgeons had the CTA, and they put down what they were going to do, and they did exactly the same things. And they said, this proves that the CTA is as good as. And I said, how often is the CTA unreadable? I mean, some blooming or some other artifact. And he said, oh, these new ones are really, really good. Well, I don't think that's most of our experience. The CTA is good, but not that good at present. What I'm talking about here is this new photon counting. And I don't know how good it is for that. I don't know how good it is for telling us that we got high lipid content, but all those things are going to be visible. And at some point, it's going to tell us whether our medical therapy is being effective. And it's going to give us the opportunity to look at a patient 6 months, a year down the road on dropping their LDL down to the teens or something and see whether this is really helpful. I mean, I think it's going to play into medical therapy and preventive cardiology as well as it's going to play into intervention or surgery.
Well,
So
thank you so much.
training of cardiologists is going to be very different. You're going to have to learn a whole lot of new tricks, but that's what young dogs are for, learning new tricks.
Thank you so much. Anybody else have any comments or questions? If not, then we'll close. Thank you again so much for a wonderful presentation and the stories. And, you know, these are things that we will never get from reading a book. So it's always good to actually hear.
I didn't know anybody read books anymore anyway.
That's right. All right. Thank you, everyone. And I'll see everyone next week.
The preceding program is copyrighted by Emory University.